Welcome to this explainer. In our 50-state series, we're bypassing general program summaries to focus strictly on how individual states are operationalizing the CMS Rural Health Transformation Program. Today, we're looking at exactly how the state of Alabama differentiates its implementation strategies under the federal guidelines.
Here's our roadmap for today. We'll start with an overview of Alabama's program implementation, look at their target populations and demographics, and outline their 11 specific healthcare initiatives. Then, we'll map their alignment with federal strategic goals, assess state policy and regulatory actions, and finish up with their implementation and sustainability timeline.
All right, Section 1, Alabama Program Implementation Overview, focusing on the federal baseline and the state's primary focus.
Let's start with the baseline numbers. Alabama's initial federal fiscal year 2026 funding allocation is strictly calculated at just over $203 million. Now, this figure represents their exact portion of the program's initial distribution. It's a combination of the uniform baseline funding that everyone gets, plus the state-specific workload funding, which is determined by federal scoring formulas.
According to the CMS 50-State Spotlight document, Alabama differentiates its application by targeting these three primary clinical focus areas. So rather than spreading the funds out uniformly across all the allowable categories, the state has really pinpointed specific service deserts, like digital obstetric care and regional oncology networks, as the primary vehicles for its rural healthcare transformation.
Moving right along to Section 2, Target Populations and Demographics. Looking at the rural facility and population score factors Alabama used to justify these operational targets.
This data is adapted right out of the state's Project Narrative Table 2, and it objectively quantifies their systemic vulnerabilities. The state is servicing a rural population of over 1.6 million people. But more critically, look at the financial exposure of their acute care networks. Uncompensated care was at $799 million in fiscal year 2020, and 99% of general acute care hospitals rely on Medicaid disproportionate share hospital payments. That baseline financial instability is really the core vulnerability the state has to address here.
Section 3, Alabama's 11 healthcare initiatives, breaking down their categorical subaward frameworks.
To service those demographics, the state basically splits its operational focus between back-end modernization and direct clinical care. On the infrastructure side, they're investing in a collaborative EHR, IT, and cybersecurity initiative to establish regional shared service hubs rather than leaving hospital systems completely isolated. Those tech foundations then support direct clinical expansions, like digital obstetric regionalization and EMS teleconsults, allowing smaller local facilities to actually deliver higher acuity care right there in place.
Furthermore, their human capital investments are strictly structured around these workforce and training pipelines. Instead of just relying on immediate, short-term recruitment incentives, the state is funding actual structural training capacity. We're talking about curriculum funding for the newly established Alabama School of Healthcare Sciences, plus establishing or expanding rural graduate medical education. It's all aimed at creating a sustainable, long-term pipeline of regional practitioners. This quote directly from the ADICA Notice of Funding Opportunity really illustrates the state's methodology. By utilizing specific NOFOs, Alabama is mandating practical, scalable delivery models rather than unconstrained capital spending. By emphasizing things like telehealth and minor infrastructure upgrades, the state aligns perfectly with the federal limitations that cap structural capital expenditures at 20% of the total award. Next is Section 4, Federal Strategic Goal Alignment, where we evaluate how they're mapping state execution directly to CMS statutory requirements.
As Table 3 from the project narrative outlines, Alabama systematically links its planned activities to those federal mandates. For example, their EMS Treat-in-Place Teleconsults initiative is mapped directly to the federal goal of sustainable access, and the conversion of community mental health centers into the CCBHC model that directly fulfills the statutory requirement to fund innovative care. Moving to Section 5, State Policy and Regulatory Actions, covering the Technical Scoring Factors Assessment. A really critical component of the federal workload funding calculation relies on the state's existing policy landscape. Reviewing Table IV of the Technical Scoring Factors, Alabama outlines its regulatory standing. They maintain active participation in multiple interstate medical licensure compacts, like the IMLC, Nursing, EMS, and SIPACT. Furthermore, the state is leveraging pending legislative actions, such as introducing House Bill 31 for SNAP nutritional waivers to fulfill the policy commitment factors required by the federal scoring rubric.
Now, a required baseline assessment under those technical scoring factors involves objectively documenting current regulatory constraints. Alabama explicitly acknowledges in its application that nurse practitioners operate in a reduced environment. Pharmacist independent prescribing faces barriers to innovation, and dental hygienists face a restricted scope. They aren't sugarcoating it. This just reflects the objective operational reality that subawardees will face when deploying these workforce initiatives.
Finally, Section 6, Implementation and Sustainability Timeline. Let's review their federal compliance path from fiscal year 26 to 2030.
This timeline tracks the strict federal reporting structure. It kicks off with Budget Period 1 distributions in Quarter 1 of fiscal year 2026, followed quickly by formal RFP processes. Notice the hard transition point at fiscal year 2030 for establishing shared service models. That all leads up to the strict mandate that any unspent, redistributed funds must be returned to the U.S. Treasury by October 1, 2032.
And we absolutely have to talk about CMS FAQ 66. The authoritative CMS post-award FAQ document dictates the parameters for program completion, and it strictly forbids using these funds as a temporary infusion without a long-term continuation strategy. States are mandated to implement internal controls to ensure that these initiatives meet a minimum 5-year service requirement far beyond the life of the RHT program itself.
So how does Alabama actually address this federal mandate? The state's project narrative explicitly outlines a transition plan moving from grant-supported implementation to self-funded maintenance. They state that by fiscal year 2030, the program will establish durable shared service and group purchasing models. The theory here is that consolidating shared cybersecurity and IT services will lower overhead costs enough that existing telehealth billing and standard reimbursement mechanisms can sustain operations without ongoing federal funding.
Which brings us to the ultimate question for policy analysts reviewing this structural approach. Will transitioning grant-funded infrastructure to regional shared service models actually provide enough long-term financial stability to permanently offset the systemic vulnerabilities of rural healthcare networks? The success of Alabama's implementation won't be judged by how the $203 million is spent today, but by whether these regional frameworks can independently survive the demographic and financial pressures we saw in their own data tables. Thank you for joining us for this explainer of Alabama's program implementation.